Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and pretty much anything else infectious disease or infection prevention which may occur to you. Also, we are very happy to welcome any listeners from outside of Arizona, and certainly we'll be happy to answer your questions as well. This is the first week of October 2023, and hopefully many parts of the country and little parts of Arizona are starting to experience some fall weather. Along with that, of course, we can anticipate the onset of the fall viruses and kids going back to school and sharing all their fun little plague vector things. So if not already, we certainly can expect an increase yet further in respiratory viruses, and including in SARS coronavirus 2. Certainly in Arizona, we've had a blast fax from the Arizona Department of Health Services that RSV is on the rise, not surging necessarily, but the preceding now 4 weeks have each week seen an increase in reported cases to the state lab. So that is enough to trigger the warning and saying that RSV is certainly not here. It is about to become so fairly significantly. And of course, for those of you tuning in from other parts of the country, especially along the East Coast, Florida, New York, Georgia, also all reporting surges in RSV. So it is that time, of course. What does that mean in terms of practice management, etc.? Number one, of course, infection prevention. So starting to consider whether to cohort sick visits, either doing like an afternoon sick clinic or bringing patients back immediately to a room if they present with fever, congestion, etc. For those of us working in the hospital setting, now is the time to consider visitor limitations, certainly for the neonatal ICUs, because nobody ever wants RSV to enter into a NICU. I've been there when that happened. It's not pretty. So considering limitation of pediatric visitation, like, siblings, etc. and so forth, but also with the newly approved and being, as we speak, released nirsevimab or Beyfortus, for those of you who can't pronounce the nirsevimab, the newest monoclonal antibody passive vaccination against RSV, which is available for infants up to 8 months of age. Now is the time to start that if you haven't already. And certainly the data on efficacy is really quite excellent. We'll actually talk a bit more about RSV interventions with one of the questions coming up. So some excellent questions as always. First several have to do with COVID-19. Astute listeners will have noted, if you listen to the last podcast, that I was asked about, would we ever see a return of the free COVID-19 test kits from the federal government? And I said absolutely definitively unlikely. And as soon as that podcast was released, and I kid you not, within 4 hours came a notice from the Biden administration like, yeah, we're going to release test kits. We've contributed $6 billion to this, and just to make me a complete and total liar and unclear on the concept. So yes, there are now, as of September 25th, so currently as we speak and listen, there are now available free test kits once again through the federal government with the same mechanism of contacting and the same sending of 4 test kits per requester. And these are all sort of the same rapid antigen based, in some cases nucleic acid testing based, but at least the ones from the federal government that are being released are the rapid antigen based. And in many cases, they've had their expiration dates extended. So the free COVID-19 test kits are available. They're out there. I imagine that also will be extending to county health departments that will once again get in supplies that can be then serving as a local distribution center. Perhaps there may be the possibility, especially for our colleagues working in federally qualified health centers, to also get a batch of test kits delivered. But for personal use and certainly to recommend to patients and their families, they can request a delivery of those. And at least from the last time experiences, it usually takes about 2 weeks for delivery to occur. The follow-up and related question then, were all at-home COVID test expiration dates extended by the Food and Drug Administration? Short answer is no, but many of them were. And one can actually find updates about this on the FDA website. Just search fda.gov, or even you can search, free COVID test kits and click on the link to the FDA. And on that link, there are then links to find a chart which identifies each of the commercially available test kits, ones across the counter and stores, ones that will be released by the federal government, and on them will be what their current expiration dates are and whether those expiration dates have been extended. The process to extend a COVID-19 test kit's expiration date comes from the manufacturer of the test kit providing evidence to the FDA that the quality assurance, that the sensitivity, specificity, function, detectability, positive, negative predictive value, all those fun things of their specific test product is viable and valid to a certain point past the expiration date. And in most cases, due to the way these tests are actually being constructed and released, there's really not much in the way of fall off in terms of test sensitivity and specificity. So the reagents, the dried reagents and or the liquid bottles, unless there's of course leakage or heat damage or something like that, are expected to be active and at 100% activity for far longer than the typically assigned expiration date. So one could reasonably make that assumption, but to be sure, just search the FDA.gov website and you will find your way to the list in chart form of the various test products and what their expiration dates are. Next question. Are we still seeing a lot of children diagnosed with long COVID or post-acute COVID-19 syndrome? There are a couple other initials suggest that, but long COVID is, as we all know it. Short answer is no. With the Omicron variant and all the sub-variants of Omicron, the number of patients both in the adult world and in the pediatric world with long COVID have decreased, not disappeared, but decreased. And in pediatrics already, thankfully, we had a slightly lower risk of long COVID, where in the adult population with all the former subvariants like the alphas, betas, deltas, there was anywhere from a 30 to a 50% risk of prolonged symptoms of COVID lasting past 2 months after onset. So what would now be considered long COVID. In pediatrics, that risk was far closer to 10%. Some variability in the series that were published, anywhere from 5% up to 18%, but on average a 10% risk. Nowadays, it is fairly uncommon, at least in my practice, to have patients referred to me with symptoms consistent with long COVID, but occasionally I will see a patient referred for something completely unrelated who happens to have had COVID in the preceding summer, so a year ago, and may still have some residual cognitive dysfunction or exercise fatigue or something like that. In speaking to our colleagues in sports medicine, and I say that specifically because it has been our sports medicine interventions with cognitive physical therapy, exercise physical therapy, that have seen a burden of our referrals for long COVID. But in speaking to them just at a conference several weeks ago, they have not seen a long COVID referral in pediatrics for quite some time. So it's a bunch of anecdotal and observational data. There are no recent studies in terms of current data and prevalence or incidence of long COVID to point you to. What's being published and still being published is retrospective experience from even former variants of COVID, of SARS coronavirus 2, especially the Delta variant, which was quite robust in causing long COVID. So we're just not seeing a heck of a lot of it. But there are going to be those patients who will have, for a variety of reasons, continued fatigue, the so-called brain fog or cognitive dysfunction, the decrease in exercise tolerance, exercise intolerance, etc. And there should continue to be just that little thought in the back of our head: is there or potentially could there be cardiac dysfunction? That's the sort of the big thing to be aware of in those patients with long COVID symptoms, most of which we now understand to be due to immunologic disarray triggered by infection with the SARS coronavirus 2, affecting the microglial cells and other surrounding support cells in the brain, with localized inflammation inhibiting or decreasing neuronal function. So indeed, that cognitive dysfunction, that brain fog, was decreased neural processing. And indeed, the chronic fatigue and the aches and the pains were actually due to neurologic impact of that. So there is immunologic reason for there to be or to have been long COVID. However, in the mix of all those patients were also that subset who had specific SARS coronavirus 2 immunologically based disease of the myocardium, or in fact every cardiac tissue had the potential to be affected, because most tissues in the body which express the ACE2 receptor for SARS coronavirus 2 can be affected. There are some tissues like the brain and the cardiac tissues that have a higher density of ACE2 receptors, hence the ability to bind more SARS-CoV-2 and to trigger a more robust localized immune reaction. So, as that patient comes to you with a distant history in the last several weeks or months or even the last year of COVID-19, and they have persistent fatigue or difficulty concentrating in school, in addition to being very, very, very aware of mental health issues associated with the past now almost 3.5 years at least, do at least consider the possibility, could there be cardiac dysfunction? Have at least somewhat of a low threshold to at least request an EKG in the office if you can, and or to consider whether that patient does ultimately need referral to peds cardiologists for further testing. Absolutely not saying that every patient needs that, but just I want us to be aware of that possibility and to act accordingly. Otherwise, for those patients who do have the cognitive dysfunction, as with many of our patients who are chronically fatigued after Epstein-Barr virus infection, or in our neck of the woods after valley fever, for example, the same interventions hold true, which is they may need a graded escalation plan for education. They may need a modified education plan, just as if they have exercise intolerance, they may need a graded physical exercise escalation plan. They may need evaluation by a cognitive behavioral therapist and support with physical therapy or cognitive behavioral therapy with specific cognitive exercises. A wonderful place to turn, and a huge shout out to our colleagues in sports medicine, are their clinics, especially those that specialize in traumatic brain injury, because the approach and the interventions are very much similar, if not identical. So yeah, that's a whole bunch about long COVID. It's not gone yet, but it's certainly lower numbers. And if and or when you have personal experiences with success stories in treating patients with long COVID, please feel free to share with this podcast so I can share it with everybody else. There is not yet any proven intervention other than the behavioral therapies, the cognitive function therapies, that has any benefit for long COVID. A thought that updating their vaccine status might be beneficial, but there was selection bias in those studies. They thought that Paxlovid might positively impact on long COVID, but once again, no discernible benefit in any sort of placebo-controlled way. So it ultimately ends up being our own techniques to support our patients with progressive therapies, and if that works, let us know. That'd be fantastic. Turning now to RSV, as promised, the question is, would I recommend the RSV vaccine in pregnant mothers? Has it shown any protection against RSV in their babies? Yes and yes. Again, very short answers to that. 100% emphatic yes and yes. The outcomes and the efficacy data specific to infants born to mothers who receive the maternal RSV vaccine have been really quite excellent. So upwards of 80 to even 90% protective efficacy to the babies against hospitalization to an ICU with severe RSV for at least the first 3 months after delivery, and protective efficacy even up to 65% for those babies up to 6 months or so. Really excellent protection if mom is immunized with the RSV vaccine specifically for pregnant mothers at least 2 weeks before delivery. 2 weeks because she needs time to mount her own robust IgG response to RSV, and to then allow that to cross transplacentally to the baby, and then baby to be born with maternal IgG, which usually lasts in a seroprotective fashion in baby's body up to about 6 months of life. So yay, fantastic, wonderful. Safety issues. There have been just small numbers of concerns about preterm labor and 1 or 2 small signals about fetal demise in those patients. However, when you compare those to general trends in the pandemic and with other viruses out there, those numbers wash. So the current recommendation by AAP, by ACOG, the American College of Obstetrics and Gynecology, by CDC, NIH, FDA, etc., is all in support of maternal vaccine against RSV for its protective benefit for the babies. 100% yes, that would be a great way to go. What about nirsevimab or Beyfortus, which is the newest monoclonal antibody vaccine, passive immunity to babies? That also has shown superior protective efficacy against severe RSV disease, against RSV disease in babies who received it, and no safety signals that have emerged, and so that product also has been approved through the FDA and CDC chains, and there's really no reason not to administer that also. Certainly now, today, as we see RSV starting to increase around the country and up to 8 months of age, and during the time of the RSV expected clusters of cases. So now into early spring, and depending on where you live and practice, that end of RSV epidemic date can be anywhere from February to even sometimes April or May. It takes some time. If you're looking for guidance on whether RSV is prevalent in your community, certainly your local county health department will have such numbers as are available, typically released through a reporting mechanism to the state laboratory, as in Arizona, and those reports can also be found based on either zip code or certainly by county. So you can search those yourself or contact your friendly and wonderful public county health officer and ask for their input about RSV in your neck of the woods. But regardless, I think we can reliably count an RSV out there wherever we're practicing in the United States. Now is the time to consider nirsevimab beyfortus. Biggest concern that I have encountered, not so much safety issues because it's been found to be very safe and effective, but more the cost, which is a little over $500 for that injection, and how much of the cost might be covered by various health insurance providers. Vaccines for Children, VFC, as of right now, is covering over $300 of that $500 cost, and there's the possibility, and being considered from what I hear from our county officers, that the entire cost might be covered. That's being considered right now by VFC. Yay, fantastic, wonderful if your patient population are largely VFC candidates. For those who are under other forms of insurance, and certainly the private insurers, no reliable word yet on which insurance providers are covering how much of the cost of the nirsevimab. That said, if you compare the $500 cost of a single injection to the previous cost of palivizumab, which is the first product, which was given as an infusion injection every month for the entire RSV season. So 4 or 5, sometimes 6 infusions for the at-risk babies, each at a cost of $1,000. Total no-brainer, right? You would think. Like, it's a certain benefit in terms of cost analysis. The only challenge, though, is that nirsevimab is indicated for every single baby, not just those who are born with prematurity, with chronic lung disease, with congenital heart disease. So in terms of medical dollar impact in the United States, as the insurance payers are going to argue, the overall cost of nirsevimab, because its indications are completely inclusive, is going to be much, 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 much larger. Yes, this is true, but also look at the preventative cost analysis. So if anybody has had one of their patients as an infant admitted to hospital and or to ICU, you know that that's not a short admission. Most typically that's several days to a week or so as the baby is on oxygen, and certainly if they're in the ICU with respiratory failure, that is a very prolonged admission, costing easily close to $1 million, if not more. So ultimately, if we are having these professional adult conversations with our insurance providers, pointing out that comparative cost benefit and societal health and protecting the health of babies, all these would support using nirsevimab with as much support as possible, as freely as possible, would be fantastic. Important question that has come up and that I don't yet have an evidence-based answer to: what about the baby born to mother who received the RSV vaccine? Does that baby also deserve nirsevimab? Well, if you look at the protective efficacy of the maternal vaccine, it is fantastic for the first 3 months, and it's still pretty darn good even for the second 3 months of that baby's life. So might there be any added benefit of the nirsevimab? Well, I suppose yes. I mean, it's kind of like I'm a belts and suspenders person, so not really, but you get the picture. There could be additional benefit just to get that protective efficacy up to as close to 100% as possible, but in reality, the protective benefit of maternal vaccine is so good in the first couple months, it's really hard to justify the added either cost and or pain of an injection to a baby in their first 3 months of life. Perhaps in the second, from months 3 to 6 months for the baby, if one is still in RSV season, there might be a slight different change in the equation just because the protective benefit of maternal vaccine is starting to wane and baby's risk is starting to increase, and thus they might benefit from nirsevimab as well. However, where that pinch point occurs, where the transition occurs, and is there truly any additional benefit to nirsevimab on top of maternal vaccine has not yet been tested nor commented on officially in the literature. The AAP, with its flow chart of how to manage such patients, says that you can consider not administering nirsevimab to those babies who have been born to moms with RSV vaccine, but consider not a definitive, yes, no, maybe, perhaps. So at least you know the issues surrounding that. How risk averse is your family? Does the baby, other than being like a full-term healthy baby, does the baby have risk factors that would truly put it at even higher risk of severe disease? By which I mean born premature or even late premature? Is there chronic lung disease? Is there some other, like a congenital heart lesion, which would increase the risk of a bad outcome with RSV? If so, then I think being far more cautious and considering a both-and approach might be the way to go. So there you go. That is what I've got in terms of opining about RSV. Other things out there, yes, we are still seeing rhino/enterovirus. We are still seeing slight increase in pediatric patients admitted with COVID-19, sometimes specific with the so-called COVID croup. And yes, this is a very dense, difficult to treat laryngotracheal bronchitis croup requiring more than a dose or two of dexamethasone. It's certainly requiring a lot of racemic epinephrine. So those patients are absolutely still coming in through the emergency departments. So too are the typical run of patients with other respiratory illnesses, triggering wheezing and respiratory illness or reactive airway disease, triggering for those who have asthma underlying an asthmatic exacerbation. We're still seeing an increase in new diagnosis type 1 and insulin-dependent diabetic patients with diabetes, and we're still seeing all the other fun stuff as well, including the still summertime viral gastroenteritis and still yet group A strep. So it's an exciting time to be an acute care provider, and certainly the ID world, and I imagine all of you as well, as these patients are calling and or coming into your clinics in the outpatient world asking, looking for additional help. So pretty much anything and everything is out there, and it's just about time to see yet more RSV. So with that, thank you as always for listening to ID Talk. The Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona and other infectious diseases, or to learn how to become a member, please visit us at azaap.org. Meanwhile, a huge shout out to everybody out there, those in Arizona, those elsewhere. Thank you all for fighting the good fight. Keep the questions coming, and know that you are all appreciated. Thanks again so much for listening.